Topic of the lecture today is valvular and endocardial diseases. So it's going to involve two things, valves and the endocardium. Valves, we all know the valves. We all know mitral valve, aortic valve, tricuspid valve, pulmonary valves. Now these valves are going to be affected. And what is endocardium? Endocardium is the membrane which lines the heart, which lines all the interior of the heart, all the structures present in the heart. So anything regarding this will be discussed in this lecture. First of all, let's get into the topic we have discussed the most, that is bacterial endocarditis. What is bacterial endocarditis? Bacterial means it's going to involve bacteria, and endocarditis means the inflammation of the endocardium, inflammation of the membrane that lines the interior of the heart. So what are going to be the basic causes for bacterial endocarditis? It's very common. We have this name right beside it. Bacterial endocarditis, meaning inflammation of the endocardium due to the bacterial infection, due to the bacterial infestation. So if the name is bacterial endocarditis, it means that it's actually a subcategory. It's a subcategory of endocarditis. There must be other categories in which other organisms must be doing the same thing. Yes, there are. It involves other pathogens too. But right now, the topic we are discussing here is bacterial endocarditis. So let's talk about which bacteria are going to cause bacterial endocarditis. The bacteria which involve and cause this bacterial endocarditis are basically Staphylococcus aureus, Streptococcus pyogenes, and these groups of bacteria are basically involved. Even Streptococcus epidermidis is also involved. We're going to discuss about the microbes which are involved in causing this disease in a later slide. But for now, let's look at this gross structure of bacterial endocarditis. Now, this is what happens when bacterial endocarditis manifests in a person, manifests in a patient. You see the inflammation of the endocardium, you see this structural abnormalities. All of this is because of bacterial endocarditis. Now, what are the common causes? I told you the common causes. I told you that Streptococcus pyogenes. I told you that Staphylococcus aureus. I told you Streptococcus viridans, epidermidis. All of these are basic causes, common causes. But what are the uncommon causes? What are those microorganisms which are not common in causing bacterial endocarditis, but one day or another day, one case or another case, they appear to be the cause? And three basic organisms lie under this category, and they are chlamydia, fungi, and rickettsia. So a patient is suffering from chlamydial infection is going to get bacterial endocarditis in 2 out of 100 cases. If it's a fungal infection, it may lead to bacterial endocarditis. If it's a rickettsial infection, it may lead to endocarditis. The meaning of telling this is that if a patient is suffering from all three or one of them, you have to be very observant about bacterial endocarditis. That if a patient is suffering from chlamydia, we have to have these markers over that patient, that we have to have these checkups on that patient, that if that patient is developing bacterial endocarditis, yes or not, because there's a high chance of developing bacterial endocarditis in those patients. That's why we have to be more aware of this fact that these infections or these infestations may also lead to bacterial endocarditis. Next on, let's talk about the types of bacterial endocarditis. There are basically two types of bacterial endocarditis called acute and subacute. As the name tells you, that acute means it will happen it will happen suddenly, and it will lead to its consequences suddenly. On the other hand, subacute will be a milder form of bacterial endocarditis, and it will develop over a longer time, and it will go on for a long time. And we will have longer and longer time to do something about it, to manifest something about it, to treat it. So first of all, we have bacterial endocarditis, meaning bacteria led to the inflammation of the endocardium. It's divided into acute bacterial endocarditis and subacute bacterial endocarditis. What lies in acute bacterial endocarditis? It's going to cause the infection of the normal cardiac valves. Now, before we dig into the normal and abnormal cardiac valve, let me tell you, all the cardiac valves in a normal person are normal. This is a normal cardiac valve. When are the cardiac valves abnormal? The cardiac valves are abnormal if they have been subjected to some kind of pathology before bacterial endocarditis. Can you give me an example? Rheumatic fever is one of those examples. Rheumatic heart disease is one of those examples in which the normal cardiac valves underwent some pathology, some changes due to rheumatic heart disease, due to rheumatic fever, and led to the formation of abnormal cardiac valves. So that's how we differentiate between abnormal and normal cardiac valves. That normal cardiac valves have not been subjected to any kind of pathology before, and they are there and they're doing their perfect work. On the other hand, we have abnormal cardiac valves which have been subjected to or objected to some kind of pathology which was due to rheumatic fever or any of other diseases which affect the cardiac valves in any way. So we know that for now that acute bacterial endocarditis is not going to affect the abnormal cardiac valves. For example, a patient who has been through rheumatic fever has abnormal cardiac valves, one or two, but what acute bacterial endocarditis does, it affects only the normal valves. And majorly it goes and affects only in those patients who have not been subjected to that kind of pathology before. The patients who have been living a perfect life, the patients who have never been subjected to any kind of cardiac pathology ever. So bacterial endocarditis leading to acute bacterial endocarditis will only be affecting the normal cardiac valves, the people who have not been subjected to any kind of cardiac pathology, the patients whose valves are pretty perfect and have not been undergoing any kind of pathological consequences. So which organisms are going to cause this? I told you, Staphylococcus aureus and Streptococcus pyogenes. These are the two basic organisms causing acute bacterial endocarditis. So both of these organisms are going to affect the normal cardiac valves, and they affect very rapidly and they destroy these valves. So by the name of acute, we said acute is going to be sudden, it's going to be in a snap, it's going to affect these valves, it's going to destroy them. And you know what? Even in acute bacterial endocarditis, death is also one of those consequences. It just tells you that how severe acute bacterial endocarditis is. It involves the Staphylococcus aureus and Streptococcus pyogenes, and it affects valves rapidly and destroy them. And because it destroys them, what will happen? When the valves are destroyed, either stenosis, regurgitation, and all the cardiac effects and all the cardiac pathologies will start coming in. That will lead to cardiac hypertrophy, that will lead to cardiac failure, that will lead to CHF, that will lead to a person dying even. That's also one of those consequences. So this is acute bacterial endocarditis, which happened in a snap, which happened over, this whole process goes on in weeks. It doesn't take a month even. 2 to 3 weeks, all of this is done. So let's go into the subacute bacterial endocarditis. Now, they are less fulminant, less virulent organisms. They have less virulency, they have less fulminancy. So what are those organisms basically? We're going to talk about them in detail. They infect structurally abnormal valves. What do you mean by structurally abnormal valves? Structurally abnormal valves are those valves which have undergone some kind of pathology before all of this. For example, a patient who suffered from rheumatic fever. For example, we talked about rheumatic fever in the last lecture. If you have not seen that lecture, you can go back and watch that lecture. But in that lecture, we told you that rheumatic fever is actually a disease of the children. It affects basically from 7 to 11 years of age. And when 7 to 11 years of age, children between 7 to 11 years of age are affected, okay, they might get better with time, but the valves are affected. Now, those valves can get infestated, or those valves can get attacked by these less fulminant organisms. Which are those less fulminant organisms? Let me give you an example right now. We can discuss it later in the next slides. But for example, epidermidis, Streptococcus epidermidis is one of those less fulminant, less virulent organisms which cause subacute bacterial endocarditis. So a patient developed rheumatic fever in the childhood, was treated, fine now, but over the time that patient develops some kind of bacterial endocarditis. What kind of bacterial endocarditis would that be? It will be subacute bacterial endocarditis, because these organisms are going to affect these structurally abnormal valves which were a consequence of rheumatic fever in the childhood. So that person is going to develop subacute bacterial endocarditis. I hope this acute and subacute is clear to you now. Next on, we have predisposing factors. Which factors predispose in the formation of bacterial endocarditis? First of all, we have intravenous drug abusers. How is that possibility? How is that a possibility that an intravenous drug abuser leads to bacterial endocarditis? Let me explain it to you. Let me break it to you. That when an intravenous drug abuser abuses himself and injects those drugs into his veins, he's actually not doing it in a proper way. He's actually abusing himself. There are microbes there, there are organisms there, there are multiple factors there that will lead to the entry of those bacteria or those organisms we talked about that lead to bacterial endocarditis along with that drug. For example, Streptococcus epidermidis or Staphylococcus aureus is present right here on the surface, and when he injects himself again and again on the same spot, that hole develops, that path develops, and those organisms can travel into them. Those organisms can get into those veins with that syringe even and lead to the formation of bacterial endocarditis, lead to the heart. They get to the heart, and basically the chambers which are going to get affected in intravenous drug abusers are right chambers, because the blood that's going to be affected is of veins. The veins go into the right chamber of the heart, and when the right chamber of the heart gets to that blood, it already contains these organisms, and those organisms will stick there. Those organisms will lead to that pathology, and the right sided or right chambers will be affected in IV drug abusers. But basically, the left chambers are the basic or the main target for this kind of pathology. Next, now we have transient bacteremia. Transient bacteremia meaning that if there was any infection inside the body, if there was any infection already in the body and it has been there for a long time, that may also lead to the bacteria leading to cardiac muscles or leading to cardiac pathology of bacterial endocarditis one way or another way. Next, now we have diabetes and pregnancy. Now, diabetes and pregnancy, both of these increase the chance of developing bacterial endocarditis in patients. In diabetic patient, immunity is already low. In diabetic patient is already going through a lot of pathologies, and there's not enough immunity to prevent these diseases or pathologies from happening. So diabetic and pregnant women are going to be more affected by bacterial endocarditis in these cases. Elderly patients have more chances of developing bacterial endocarditis because their valves are already stiff, their valves are already calcified in some ways. They're at more risk of developing bacterial endocarditis. Next on, we have prosthetic valves. When prosthetic valves are applied, there's more chance of developing bacterial endocarditis because these prosthetic valves can even attract these organisms, and the colonies will develop there, and this will lead to bacterial endocarditis. So these five are actually the predisposing factors. Which predisposing factors we talked about? First of all, it's going to be IV drug abusers. Second of all, diabetes, pregnancy, transient bacteremia, elderly, and prosthetic valves. Now, these all are etiological factors for developing bacterial endocarditis. Next on, we have other etiological factors which involve our heart itself, and those are congenital heart disease. What congenital heart diseases we're talking about? ASD, PSD, right? Congenital heart diseases may be their valvular calcification, which happens in basically the elderly patients or in other kind of pathologies valvular calcification can happen. So this is one of those etiological factors. Rheumatic heart disease, we talked about rheumatic heart disease. Rheumatic heart disease is the basic etiological factor regarding the cardiac pathology, regarding the cardiac diseases. It affects those valves, it destroys those valves, and when those valves are destroyed, which kind of bacterial endocarditis will be happening? Subacute kind of bacterial endocarditis comes here and affects it. Next on, we have mitral valve prolapse. Next on, we have intravenous drug abusers. We talked about intravenous drug abusers. What is mitral valve prolapse? Mitral valve prolapse happens when there's a long-standing pathology with the mitral valve. And under a lot of pressure, these chordotendonae and these go long, they just propagate and they weaken, and any of the stress-related disorders or pathologies will lead to mitral valve prolapse, and this is one of the basic etiological factors of bacterial endocarditis, because it will give a perfect environment for all those organisms to just come here and stay and cause bacterial endocarditis. We talked about the etiological factors which are not cardiac in nature, and then we talked about the etiological factors which are cardiac in nature. So all of these 9 to 10 etiological factors combined are the basic reason why we develop bacterial endocarditis. Now, which microbes are the basic organisms which lead to bacterial endocarditis regarding bacteria only? First of all, we have Staphylococcus aureus. Now, Staphylococcus aureus is the most virulent, most fulminant one. This will lead to acute kind of bacterial endocarditis, and it has those consequences in a very short time, and it may lead to even the death of the patient. So Staphylococcus aureus, whenever the name bacterial endocarditis comes out, whenever the name bacterial endocarditis, you hear the name bacterial endocarditis, you should remember this name, Staphylococcus aureus. This is a basic organism causing bacterial endocarditis in the acute form, not in the subacute form, in the acute form. What does it mean to be in the acute form? It's going to affect the healthy normal valves and lead to their pathology and lead to the pathological consequences. Next on, we have coagulase negative staphylococci. Now, these are also the microbes which affect and cause bacterial endocarditis. Next on, we have streptococci. Next on, we have enterococci. We have fungi, and then we have gram-negative bacteria. So these are 6 microbes which affect it. And one microbe that we discussed before but is not here is rickettsia. Right? So Staphylococcus aureus being a major one, then streptococci, which are Streptococcus pyogenes, Streptococcus viridans, those are involved. Coagulase negative staphylococci are involved. Enterococci are involved. Fungi, any kind of fungal infection can lead to this. Gram-negative bacteria are one major reason of developing bacterial endocarditis. So you have to keep these 6 groups in your mind whenever you hear the name of bacterial endocarditis. But basically, it's Staphylococcus aureus. Remember that. Next on, we have molecular pathogenesis. What's the molecular pathogenesis of bacterial endocarditis? How does that normal valve or abnormal valve had gone through some consequences and led to bacterial endocarditis, led to the inflammation of the endocardium? Now let's discuss it. First of all, there are hemodynamic factors and formation of platelet, fibrin, thrombus. What are the hemodynamic factors? What's the formation of platelet, fibrin, thrombus? Let's discuss about the subacute kind of bacterial endocarditis. Let's take that in mind for now. So what has happened in subacute bacterial endocarditis? What's the condition of the valves? They are affected badly. They're affected because of rheumatic fever beforehand. So if they're affected beforehand, there's some kind of pathology already there. When there's some kind of structural abnormality already there, the hemodynamic factors come in. When there's structurally abnormality there, what's the flow of the fluid? What's the flow of the blood going to be there? Turbulent. It's going to be more on the lateral sides, more on the on the edges. It's going to be more on the surface or the place where the pathology lies or that structure lies. It's going to be more turbulent. When the fluid more turbulent, what's going to happen? It's going to get more and more shed and more tear and wear. When it's affected to that kind of pathology, all those platelet fibrin will be activated, and they are going to get attached to that place specifically. They attach to basically fibrin attached to those places which get the most of the blood, which gets the center of the blood. So platelet fibrins will be activated, and platelet fibrin thrombus will develop at that point. When platelet fibrin thrombus is developed, pressure gradient across narrow orifice produces turbulent flow. We talked about turbulent flow, that it produces turbulent flow across. So pressure gradient across the narrow orifice, that orifice which has been narrowed because of rheumatic fever, because of this pathology which is happening, now that outflow has been narrowed, and this narrow outlet has produced turbulent flow. The pressure gradient will go up or down according to the pathology. So pressure gradient is going up and up and up in this case. And then the focal deposition of platelets and fibrin will come in. We talked about it. When all of this is going on, platelets and fibrin will come in, and they'll attach to the place which has the most turbulent, which has the most flow out of it. And when they're attached, expression of VCAM1 and ICAM1 and E-selectin will come in, which induce inflammation. And when there's inflammation there, when there are these expressions of these factors, what will happen? Inflammation of those structures will happen, and that will lead to endocarditis, inflammation of the endocardium. Now, this is the molecular pathogenesis of bacterial endocarditis. What's it leading to? Let's look at it. This is the diagram of bacterial endocarditis. You can see the mitral valve have these vegetations which have eroded through the normal leaflets and cause this pathology, which lies right in front of us. That's what bacterial endocarditis is. Next on, what other pathology is because of bacterial endocarditis? That is thromboembolic phenomena. And you can see in this slide that infected thromboemboli is lying here. It was a thromboemboli, but due to this bacterial endocarditis, it's been infected and it led to this kind of pathology. That's what infected thromboemboli looks like. Next on, we have clinical features of bacterial endocarditis. What are the clinical features of bacterial endocarditis? What features will be a patient presenting to you with when he's suffering or she's suffering from bacterial endocarditis? First of all, low-grade fever because of these organisms, because of this infection going on inside the body, because of this bacteremia, because of this neutrophil activation, because of all the immune system being activated inside the body, patient will have low-grade fever. Next on, the patient will have fatigue. The patient is going to experience clubbing of fingers. Why clubbing of fingers? Because cardiac pathology is lying right behind of it. Whenever there's any kind of cardiac pathology, whenever there's a murmur, whenever there's any kind of deoxygenation issue in the heart, first symptom that we're going to get is clubbing of fingers. Next on, we have heart murmurs. Heart murmurs will be there because this bacterial endocarditis is actually affecting what? The valves. This bacterial endocarditis is going to affect the valves. When the valves are affected, when they're not opening and closing in a snap, when they're not doing their work, the emptying and filling of the heart chambers will be affected, and it will be varied. And when it will be varied, it will be affected, and it won't be synchronized with the electric rhythm of the heart, with this whole potential. Then what happens? The heart murmurs will come in. What other clinical feature you will look for? Brain abscesses, because all of this will lead to thromboembolic phenomena. This may lead to embolism in the brain. This may lead to brain ischemia, and this may also lead to brain abscesses afterwards. Next on, we have more clinical features which are basically related to this bacterial endocarditis, which is anorexia. Patient is going to have anorexia. Patient won't be able to eat anything. Patient will be anorexic. Then patient will have petechiae on the body. Skin manifestations will come in. Patient will develop petechiae on the body. This will be due to this bacterial endocarditis, this infection manifesting in the heart, this infection manifesting in the body, these valves being affected, this heart pathology being manifested in the body. Then we have mycotic aneurysms. When this kind of pathology, when bacterial endocarditis comes in, there's mycotic aneurysms will come in. Aneurysms will happen, which will lead to more and more pathological consequences. Next, now we have pulmonary emboli. We told you that it's a thromboembolic phenomena. Anytime a thrombotic phenomena will lead to an embolic phenomena, and that embolism will lead to the blockage of one or more arteries, or one of the basic organs at least. One of the very basic organs that get affected by bacterial endocarditis are lungs and brain. So if any kind of pathology leads to, or this thrombotic phenomena led to the detachment of an emboli, and that goes to pulmonary vessels and causes a pulmonary emboli, this will be the pathology, this will be the gross structure looking like. This is also a consequence of bacterial endocarditis. And next on we have splenomegaly. Patient will have splenomegaly. Splenomegaly happens whenever there's any kind of infection, whenever there's blood involved. So splenomegaly is one of the basic clinical features that we will be looking for on a body exam, on a physiological exam, on a physical exam of the body of the patient which is suffering from bacterial endocarditis. Splenomegaly is one of the first symptoms you look for, and there will be a massive splenomegaly in the cases of bacterial endocarditis. Next on we have non-bacterial thrombotic endocarditis. We talked about bacterial thrombotic endocarditis. We talked about bacterial endocarditis. Now what is non-bacterial thrombotic endocarditis? It's also called NBTE. In case you are presented with that term, you have to know that it's non-bacterial thrombotic endocarditis. What is non-bacterial thrombotic endocarditis? It's also endocarditis, but it's not happening because of any kind of bacteria. It's not happening because of any kind of pathology, because of any organism. Rather, it's happening because of a basic pathology. Rather, it's happening because of a very major pathology. And what major pathologies are they? All the paraneoplastic syndromes. All the cancers may lead to, all those paraneoplastic cancers, all those paraneoplastic syndromes may lead to non-bacterial thrombotic endocarditis. Now, if you look at this slide, this is a mitral valve, structurally normal mitral valve, but you can see platelet and fibrin deposits are being deposited here. Now, this form of endocarditis, there has been no infection, there has been no infestation, there has been no bacteria, there has been no rheumatic fever before that to affect the valves. So there has been no pathology whatsoever. So in a structurally normal mitral valve, what you're looking at is platelet and fibrin adhesions are happening. Platelet and fibrins are being deposited. So that's what happened in non-bacterial thrombotic endocarditis. And this will lead to thrombotic phenomena and embolic phenomena. So that also leads to ischemia of one organ or more organs, or the death of one organ or more organs. So what you have to remember in your mind is that non-bacterial thrombotic endocarditis is basically due to a paraneoplastic syndrome or tumors or that kind of pathology, but not because of any kind of infection, not because of any kind of infective pathology. Next on we have calcific aortic stenosis. What does the word calcific aortic stenosis give off? It means the calcification is happening, calcium deposits are happening, and that are leading to aortic stenosis. And we talked about the word stenosis. Stenosis is actually what? Narrowing of the outflow, narrowing of the outflow tract, narrowing of that valve. So due to calcium deposit, due to calcification, aortic valves are being narrowed, are being stenosed. That's what calcific aortic stenosis, this term refers to. So what are the etiological factors that are responsible for calcific aortic stenosis? First of all, we have degenerative senile calcific aortic stenosis. Next on we have congenital bicuspid aortic stenosis. And next on we have rheumatic aortic valve stenosis. What's the difference between them? First of all, let's talk about degenerative calcific aortic stenosis. In degenerative calcific aortic stenosis, what happens that over the age, it has 3 leaflets, it was normal, but over the age, due to the senile factors, due to this age factor at a later age in life, calcium deposits are being there, but the commissures are not fused. The commissures have been there, commissures have not fused, but the calcium has been deposited throughout this life, and this led to calcific aortic stenosis. And it has not happened because of any pathology, but because of the senile reasons. Next on, we have congenital bicuspid aortic stenosis, in which there was a congenital abnormality of the aortic valve. When there was congenital abnormality of the aortic valve, and you knew about it or you didn't, one way or another, this had led to this congenital bicuspid aortic stenosis, in which a lot of calcium has been deposited here, and this pathology led to a turbulent blood flow for a long time. And after years and years of turbulent flow, calcium has been deposited here, and this has led to the stenosis of this even bicuspid valve, and that's what leads to calcific aortic stenosis of the bicuspid aortic valve, which was congenitally abnormal. Next on, we have rheumatic aortic valve disease, in which if a patient had rheumatic fever or rheumatic heart disease before calcific aortic stenosis or in the childhood, now those valves are now affected, those valves are now damaged. When the damaged valves are there, if the aortic valve was damaged in that rheumatic fever, this may lead to development of a lot of calcium around it. When a lot of calcium is around it, it's going to push it, it's going to cause a stenosis of that aortic valve and lead to the pathology of calcific aortic stenosis in the cases of aortic valves. Next on, we have what's the pathology of calcific aortic stenosis. You can see a lot of calcium there, a lot of connective tissue there, myxomatous connective tissue there. So all of that pathology may lead to the development of calcific aortic stenosis. Next on, what's the risk factors of calcific aortic stenosis? As you can see, this is the blood supply of the heart. Blood supply is going, this is going to supply the blood, but what's happening here? It's atherosclerotic patch developing here, embolic phenomena is developing here. So what you can say out of it is that it has the same risk factor as of atherosclerosis. What were the risk factors of atherosclerosis? That's a question for you. If you read that topic or you have been through that lecture of atherosclerosis, what are the risk factors for atherosclerosis? We talked about it: obesity, diabetes, more cholesterol levels, more fatty levels. Then we talked about that if there is any kind of atherosclerotic phenomena happening, embolic phenomena happening, all of those are the risk factors. Smoking is one of those risk factors. So all of these risk factors lead to calcific aortic stenosis. Next on, we have clinical features of calcific aortic stenosis. First of all, we have left ventricular hypertrophy. Why? Question is why there's left ventricular hypertrophy. Left ventricular hypertrophy is happening because now left ventricular hypertrophy will be happening because if aortic valve is stenosed, where the blood is going to go? Left ventricle is supposed to push all the blood to all the body. Push at least 60% of the blood present inside that left ventricle to the body so that it can meet the needs of the body one way or another. If it doesn't meet the needs of the body, cells or tissues or even organs may lead to ischemia. And when they have been leading to ischemia, the organs are gonna fail. So in calcific aortic stenosis, when the aortic valve has been stenosed due to the abnormal accumulation of calcium there, now the heart has more pumping to do. Now the left ventricle has more pumping to do. Now the left ventricle has more power, has more pressure to exert on the aortic valve to open up to certain level to push that blood out of it. So due to this massive amount of pressure, due to this massive amount of work, left ventricle is going to get hypertrophied. As you can see, now the left ventricle has went into hypertrophy. In this slide, you can even imagine the left ventricle has underwent hypertrophy. The muscles are gone. Now it's going into hypertrophy. Now size has increased. Next on, we have features of mitral valve annulus calcification. Now we talked about aortic valve calcification. Now let's talk about mitral valve annulus calcification. What are the features are going to be there? What will the features we'll be looking for? First of all, it interferes with posterior mitral leaflet excursion. What it wants to say that mitral valves can also be subjected to the development of calcification, to the calcification process. calcium can get deposited there too. It can be because of any rheumatic fever beforehand. It can be because of any pathology of the mitral valve. It can be because of any congenital abnormality of the mitral valve. It can be even of senile causes. But whatever the causes, if the mitral valve is involved in the calcification process and it involves the posterior mitral leaflet, it may lead to not only mitral valve stenosis but also to mitral valve regurgitation. If the posterior mitral leaflet is involved, it may lead to mitral valve regurgitation. Now, in this, the valve leaflets are not deformed. In this pathology, the valve leaflets are fine. Unlike the other pathologies in which leaflets are the basic structures to get affected pathologically, in this pathology, the valve leaflets are not deformed. They are normal, but the calcific deposits transform mitral ring to curved bar. Now that mitral ring has been turned into a curved bar. So the basic pathology is lying on that ring and to curve it into a bar. So the calcific deposits which were to deposit at these leaflets in other pathologies are not affecting the leaflets here. They're affecting the mitral ring and they're converting it to curved bar. So the amorphous masses develop first in the connective tissue. These amorphous masses develop first in the connective tissue and then lead to this pathology, then lead to this development of the curved bar. Now let's talk about mitral valve prolapse. This word gives off the pathology. The mitral valve is prolapsed. The mitral valve, where does the mitral valve lies? Mitral valve lies between left atrium and left ventricle. So what's going to the pathology of it? Let's talk about it. So molecular pathogenesis of mitral valve prolapse is that it's actually transmitted through your parents as an autosomal dominant trait. It's actually present on the loci of which chromosomes? 11, 13 and 16 chromosomes. On loci of 11, 13, 16 chromosomes, it is actually an autosomal dominant trait. If it's autosomal dominant trait, it's going to get there in case the both of those parents have this. So it's autosomal dominant trait. It's present on the loci of 11, 13 and 16 chromosome. What happens is that mitral valve, now prolapse, accumulates a massive amount of myxomatous connective tissue. When it accumulates massive amount of myxomatous connective tissue, it leads to proteoglycans in valves, increased collagen fibers and fragmentation. Now let's talk about this pathology with a depiction of diagram, right? Now this is a mitral valve. You can look at it. This is a mitral valve. From where this picture has been taken? Left atrium or the left ventricle? Left atrium, obviously. This picture or this depiction has been taken from the left atrium, and you can see these are redundant. These leaflets are redundant and they're coming out in the left atrium. So now just look at it, and now I'll tell you the pathology so that you can keep it in mind just by looking at it. What happens is that when a mitral valve is prolapsed into the left atrium, what happens is that this attracts a massive amount of myxomatous connective tissue. When a massive amount of myxomatous connective tissue is attracted towards it, proteoglycans get activated. When proteoglycans get activated, there's fragmentation of fibrils, there's fragmentation of collagen. With this, a massive amount of pressure, when the blood is going through that place or whatever, due to massive amount of pressure, these chordae tendineae will go weak, will go thin. And that will lead to the pathology. That will lead to this pathology we're talking about, this mitral valve prolapse. When you will take one of the microscopic slides from these leaflets, you can see is that there's massive amount of myxomatous tissue present inside of it. When you look at it, when you take a slide out of the center of the leaflet, because in the center of these leaflets, myxomatous connective tissue is accumulated. So that's what you will look for when you will see a slide of mitral valve prolapse, and then you go on and take a leaflet and take a microscopic structure and you look at it, you will find a lot of myxomatous connective tissue present in here. Next on, we have mitral valve prolapse associations. What is it associated with? It's prevalent in osteogenic imperfecta, in Ehlers-Danlos syndrome, in Marfan syndrome, and collagen-related disorders. So what does all of these have in common? There's only one similarity. There's all of these are collagen-related disorders. All of these are collagen-related disorders, bone disorders. So we can say that mitral valve prolapse is associated with collagen disorders and bone disorders equally. Or basically, collagen disorder. Whenever there's connective tissue disorder there, inheritedly or through any pathology, whenever there's connective tissue disorder, whenever there's collagen-related disorders, what's going to happen? It's going to be associated with mitral valve prolapse. Next on, we have clinical features of the patient who are suffering from mitral valve prolapse, and that is endocarditis, infective and non-bacterial. If a patient is suffering from mitral valve prolapse, it's going to invite all the microorganisms present inside the body. It's going to actually attract all of those microorganisms towards it, and this will lead to endocarditis. It can be infective endocarditis, it can be non-bacterial endocarditis, and it can be even bacterial endocarditis in some cases. But basic kind of endocarditis happening in here because there's no bacteria present before that, so it will be basically infective and non-bacterial endocarditis, meaning it can be all of those endocarditis. It can be infective, it can be non-bacterial. So this is one of the clinical features. The patient will present to you with endocarditis, and we talked about how an endocarditis patient will present to you. So you will have all of those symptoms in your mind that, okay, this is how the patient will present to you. And then you will check for any kind of symptoms which might relate this endocarditis with mitral valve prolapse. Next on, we have mitral regurgitation. Now, this is a clinical feature that you look for, mitral regurgitation. When there's mitral valve prolapse and the chorda tendini are so thin, this may lead to mitral regurgitation. This may lead to whenever the ventricles will push the blood out of it, some blood will come back into left atrium. This will lead to mitral regurgitation. And the third pathology it will lead to cerebral emboli. This thromboembolic phenomena will lead to the emboli to the cerebral area, and the cerebral area will be necrosed due to this emboli, and even the death can be a consequence of this mitral valve prolapse and the development of this thromboembolic phenomena and then embolism of cerebral areas. It may lead to even the death in some cases, but in some cases the patient won't die, but it will have cerebral necrosis and all of the consequences because of the cerebral necrosis. Next on, we have papillary muscle dysfunction. What are the features of papillary muscle dysfunction? Now, papillary muscles are very important. If any kind of dysfunction is to happen in them, what are going to be the basic causes? What are going to be the basic features? First of all, ischemia causes stunning and mitral regurgitation. This will lead to permanent mitral regurgitation may be due to MI. What's MI? Myocardial infarction. Next on, also associated with healed myocardial infarct. Even if the infarct which happened due to myocardial ischemia has healed, this papillary muscle dysfunction will propagate. This papillary muscle dysfunction will stay there. So basically, papillary muscle dysfunction happens because of ischemia. Whenever there's very minute amount of ischemia, papillary muscles get affected. Why papillary muscles get affected? Because papillary muscles are supplied by the end branches of coronary vessels. When the coronary vessels distribute its blood supply throughout the heart, only the end arteries lead to the blood supply of papillary muscles. So if there's any kind of angina even, which lasts for 10 to 15 minutes, it will lead to papillary muscle dysfunction. It will lead to papillary muscle stunning. First they are stunned, then they are dysfunction. If they are stunned for a very long time, they go into dysfunction. So angina, maybe they're only stunned, they're not dysfunctional, they're not dead. But if there's myocardial ischemia, if that angina has crossed that 15 minutes boundary, if the vessel which is supplying the heart has been blocked completely by thromboembolic phenomena or because of any vasospasm, this will lead to the dysfunctional capacity of papillary muscles. This will be permanent. This will lead to permanent mitral regurgitation or temporary. But it is associated with myocardial infarction, basically, or in major cases, it is associated with myocardial infarction. Now let's talk about carcinoid heart disease. There's very little known about carcinoid heart disease. What we do know is that it is caused by some kind of cancer, it is caused by tumors, it is not caused by any kind of infection. So in those tumors, in those cancers, in those carcinoid diseases, carcinoid heart disease will be due to high concentration of serotonin or other amines. When the serotonin and other amines are the basic reason to cause carcinoid heart disease, it basically affects the right side of the heart. Why is that it affects the right side of the heart? Because of these aminoids get metabolized inside the lungs. When they get metabolized inside the lungs, this leads to the effect of the right-sided heart exclusively. When the left side of the heart gets affected, when there's any kind of atrial septal defect or ventricular septal defect, this will lead to the left side involvement of the heart. There's a research which concluded that if a patient has been taking appetite suppressing drugs, it also involves that person is also going to get the involvement of the left side of the heart. But it's not proven yet, but this is a proposition out there that taking this kind of drugs which suppress your appetite will also lead to the involvement of the left side of the heart. Now, this is a pathological diagram of carcinoid heart disease. You can see this is a depiction of tricuspid valve. This pearly white appearance you can see, but leaflets are fine. But you can see that this carcinoid heart disease affects the leaflets in this way and leads to the pearly white appearance of it. So that's all for these valvular and endocardial diseases. What we learned about is that endothelium of the heart and valves get affected if they have been subjected to any kind of disease before, like if they have this pathology from the very birth, if this pathology is congenital, or this pathology was due to any kind of rheumatic disease which happened in the childhood. Both of these diseases lead on to endocarditis and all of these valve diseases we discussed. And we talked about an endocarditis. It can be acute, it can be subacute. Acute can be because of some bacteria. We talked about Staphylococcus aureus, and it's very quick. It causes even the most virulent of the pathological consequences in weeks. On the other hand, we talked about subacute, which takes months to develop and months to lead to its pathological consequences. Then we learned about how it's going to present to us, how it's going to be shown on the gross structures and histological structures. Then we talked about valvular pathological diseases. We talked about calcific deposits. We talked about how aortic calcification or mitral valve calcification will be looking like and what are their pathological consequences. And at the end, we talked about carcinoid heart diseases, in which we don't know much about the basic reason of the disease, but we know that this is caused by these amines which are metabolized inside the lungs, that for the right side of the heart of the lung is destroyed and affected in this, and this leads to tricuspid regurgitation, but also pulmonary stenosis. So that's all for today. Thank you for watching sqadia.com.